all of the soft care is to reduce stress, enhance self-awareness, mental health, those kind of things. Hard care is and data-driven practices focused on fitness and biohacking and those kind of things, right? Everything that
Christophe,
we thought about. Yeah.
don't care is also healthy.
Welcome to the Healthusiasm podcast, a panel discussion on innovations in health and self-care. My name is Christophe Jauquet. I'm a health business expert, author, and professional keynote speaker. Every week, I discuss with a panel of experts the positive changes that are shaping our health and happiness. And for this discussion, we have a full panel. Again, calling in from Barcelona is our digital health connector, Aline Noizet.
Hola.
From Scotland, but living near Brighton, medical expert in digital innovation, Dr. Keith Grimes.
Fit like Arbity.
We also have from Germany an expert on digital innovation in healthcare, Dorothee Marie-Louise Doepfer.
Hi.
And last but not least, from Camp Belgium, human experience expert Mo Zouina.
Goeiedag.
Goeiedag. Guys, this is the last one of the year. And I think it's good to reflect back maybe first, just briefly on this year and what we've done with the podcast, because we've evolved quite a bit, I think. I think we went from a monthly podcast to a almost weekly podcast. This is the change that we've done. We went from a form that has, it took us 100 minutes or more per podcast. That was the format that we previously had. Now we try to have shorter formats of about 30 to 40 minutes. We went from discussing one article with the 4 or 5 of us to highlighting the many health innovations that we recently came across, often in specific fields. We also started recording at healthcare conferences. We did Health Europe altogether, with its Frontiers Health, Aline and myself. And we had over 15 amazing guests on the show. This is everything that we have done this year. Now, I don't know if you are, any of you, are you on Spotify? You listen to Spotify? Did you receive your Spotify Wrapped this year? It's always, I always look forward to this. I mean, I that much love it that I gave my son at the years of 4 years old, I guess, his own Spotify account, because I hated that the whole year wrap was with his kind of music. I wanted to see what I was listening to. Now, we also have, as podcasters who publish on Spotify, we have an overview of what happened with the podcast as well. And I wanted to share that with you and with the listeners. Even though Spotify makes up only 30% of our streams, so there's 70% coming from other places, mainly Apple Podcasts. But still, it's 30%, so it's worthwhile looking at it. And so here are the numbers that we achieved this year, if you will. We have 54% more streams. So we were listened to quite a bit more than the previous year. We have almost 100% new listeners. So we doubled in new listeners. And what is interesting is that almost every new listener becomes a subscriber. So we have exactly 80% new listeners and 65% subscribe. So that's a good thing. I think that's something to be proud of. We're growing bit by bit in our third year. But one that made me smile really well as well was the fact that we were streamed in 23 different countries in the past year, which is exceptional, I think. And when you look into it a little bit closer, it's 70% comes from Europe, 14% is from the States. We have 8% in Asia and about 3% in Africa. So that's a global reach in some way, if you will. But I think it's something that I'm proud of. I mean, it's something that we love doing, but I think it's nice to see these numbers. Now, what we don't see in the numbers, and this is something that I wanted to share as well, is the fun. I think if you compare it to last year, to me, it keeps on getting more fun. I think and I hope that this is a feeling that is shared with you as well. But it keeps on being fun, and we get to know each other way better by talking to each other every other week or two. And yeah, this is what I wanted to say is like a thank you for this year again, guys. We've achieved great things, but we had most of all a lot of fun.
Yeah, nothing is more contagious than fun, but also a very, very big thank you to all the listeners, which are giving us their most prized resource, which is time and attention. So thank you very much, everyone.
let's hope that they have fun as well when they are listening to it, because that is what we try to achieve here. Back to business then. Back to the podcast. This episode will be specifically about health innovations, healthusiasms that we see in the area of health at home. And to get this topic started, launched, Dr. Keith Grimes, tell me your thoughts on it, because you are a physician. Health at home, definitely you should have some thoughts on that, I can imagine.
Yeah, absolutely. So that's right. Although I don't practice anymore, I've spent 24 years working as a general practitioner in the UK. And general practice in the UK is, grounded in continuous care. And if you want to provide continuous care, that care occurs not only in the surgery, but in the home of the patients. So in my early years as a GP back in 2000, a large part of my day was visiting people at home, delivering care for things that people actually don't generally require a home visit for these days. But I'd spent a lot of my life driving around in the morning, lunchtime, evenings, and then in my out of hours sector. So I spent a great deal of time there and understanding what it was like for people and the effect of their illness and health and wellness at home. Great privilege, sometimes quite challenging, but you get to see how people live their life. And what's interesting about this is that there is, when you work in hospitals, this perception that patients just want to go into hospital, or people just want to go into hospital. There's this sort of narrative. I can tell you, having worked in the community, it is the exact opposite. Patients are very, very keen not to go into hospital. You would spend a lot of time, sometimes even begging and pleading with patients who are very unwell to head into hospital again. And often they would stay out because they wanted to take care of their cat or their family or whatever it was. So I've seen all of this. So you would think in that situation that care at home, the desire to be able to empower people to care for themselves at home or get them home sooner, might be warmly received. And I think the headline level is, yes, it is, but the reality of it is slightly different, particularly when people are quite unwell. If you try and manage people at home, if you put together a treatment plan and get them to stay at home, without the ability for them to be able to rapidly escalate any concerns at home, that trust at being able to be cared for at home starts to fall away again. And if you're having to remotely monitor people at home, particularly in the busy world of general practice now, it gets very, very difficult to juggle that workload plus the workload back at the practice, because the expectation is often where a person's being cared for at home, then you can have that time back to see more patients. So I think from a physician side, there's still some anxieties about that, and also anxieties about whether you can trust the information that's coming back either from the patient or some of these remote monitoring devices. And then, of course, we see in the UK the rise, and probably around the world as well, the rise of virtual wards and remote care, people getting out of hospital earlier because they can have their care provided for remotely with oversight in the hospitals. And there are some companies in the UK, for example, Doepfer, that do a great deal of that. So we're seeing a lot of success there. But I still get the sense from patients that it's a bit of a mixed bag here when they're feeling particularly unwell. Even though they have remote monitoring and the ability to be able to contact someone, in certain circumstances, the idea that they're being cared for directly or someone physically with them is still very important. So if we explore health at home or care at home, those may be some useful bits of context for everyone to consider, at least from my perspective. Humans are more complex than we might like to believe.
Yeah, thank you for that perspective. And it's a perspective indeed from your side, the general practitioner, and what you've noticed. We are lucky today to have somebody from in the hospitals. So it might be good to have some perspective there, Dorothee.
Yeah, I hear you, Keith, especially as a general practitioner where you have to drink lots of shots when you have to visit the people, to have a social interaction. In a big hospital like Charité, which is one of the biggest university hospitals in Europe, you see that you cannot care as good as you would like to for all the patients really pressing into your rooms. And from our perspective, we think it's a great movement because you can take care of follow-up of surgeries and these kind of things more efficiently, because the human factor matters a lot. But if you cannot see patients because you are not reimbursed, you don't have the time, you lack of good patient care. And this healthcare at home or health at home could be a nice bridging to go back to really providing great care. So I think from a big hospital perspective, it is a good opportunity to get the trust back of the people we actually should serve. Because at the moment, we don't have any trust. The people come to us, they're frustrated. Not only here, I know in the US as well. And not only because of COVID, but they expect good care and they expect a social component we cannot give to them at the moment. So I think that's why they trust more general practitioners, because when they come to us, it's, hey, you need surgery, either yes or no. This is the amount of days you stay in. This is where you stay. And then they complain there's no nurse, nothing. So I think this could give big hospitals and communities back this care factor as well.
Lovely. I think having those two perspectives, and I think you and I, Aline, we work a lot with digital health solutions. If you look at all the digital health solutions that come out, a lot of them are focused on telemonitoring, are making sure that we can, do some telehealth, telemedicine, even try to push patients back to their home, see what they can do from their homes. Diagnostics are even at home. Having those two perspectives, I'm pretty sure that you have some thoughts there or some insights that maybe you can add to this conversation or to this discussion here.
Sure. But so what I always say is that if we look at healthcare a few years ago, when you needed to consume healthcare, you were going to the hospital, to the primary care. But now things have evolved and care is coming to us. And I think that's the beauty. And what you're saying, Christophe, like technology is really helping with that. And for me, it's really empowering all of us. So as patients, as consumers, you can do more things from home. You can really take care of your own health from the comfort of your home. If you want to check like your cholesterol level, of your hormones levels, you can just do it on your own. Like you go on the website, you order a test and you receive it at home. But maybe what's important here, like Dorothee, you were mentioning that, but for me, it's the figure of the healthcare professionals. And although it's happening at home, I think it's important to really have a follow-up and a strong and easy access to a healthcare professional. So when you do a test at home, to have the possibility to talk to healthcare professionals to understand your results. Like if you do DNA test, to talk to a genetic professional who can explain what those results means, no? And this is also that concept of digital front door. Maybe it's a bit stronger in the US, where you can just access things on your phone. You can do like a skin check on your phone. You can order your contraceptive pill from your phone. You answer a few questions. It's delivered to your home. So that's really that simplicity of receiving things at home, no? And there's also the convenience. If you think about women's health, there's a solution like Matrix in the US. So they're really like redesigning and reinventing the women's health checkup and the speculum concept with a new device, like wireless device that you can use at home. And you can do that test at home on your own, in the convenience on your home. And then when you go to the gynecologist for the annual checkup, you bring those results, but just more convenience. I see this as another benefits for the consumers and the women in that case.
Yeah, totally. And I think all of these examples and even the discussions that you had, one of the things I always try to say, and it's based on a quote from the WHO, is like we always say that 99% of caring for your health happens outside of healthcare. And then if you think about where do we spend most time, it's definitely at home. And so I like to say that our home is really the epicenter of our health. By the way, I have a keynote that specifically talks about this, where I think the keynote is titled, "Our homes are the biggest investments for our health." Because we often say that it's the biggest investment that we make in our lives. For most people, it's the case. But if you think about it, it's actually the biggest investment in our health, because there's a lot that can happen or that we need to be doing in our homes during our lives or even after that. Dorothee, you wanna chime in with your thought on that?
Yeah, I found a really nice, when preparing for this podcast, I found a really nice quote from a venture fund. Actually, they are specialized in this area. They said, like, home is where your health is. So exactly. I really like that one on Ed, what you said, and especially with our population that is getting older and older, a topic everybody talked about for ages now. But so you have more chronic diseases, and people really want to stay in their environment, and especially in remote areas. This is your home where you are, and you want to have access to healthcare. You want to have the best you can get. And if a physician is not willing to travel to see you there, so you have to make a healthcare environment around your home. So I think that's super important.
And what you see then is that there's a lot of companies that start realizing that. And I think Aline, one of the most wonderful examples maybe is from France with La Poste. What they're doing is pretty amazing. And it's everything that you were saying, Dorothee, is that people are living longer. We have an aging population. There's a lot of chronic illnesses. They're on the rise. Hospitals are overcrowded, as you mentioned before. And many people, as Keith was saying also, is that they prefer to stay at home, or they prefer to receive care at home. And so what La Poste did is they created something which is called La Poste Santé and Autonomie. And it's really to tackle all these issues. And so they have a health at home strategy where they want to make sure that patients can stay at home longer instead of going to the hospitals, where they will support indeed the chronic illnesses. And they do that with digital health solutions, making sure that the data is managed properly, that we have the data even to improve the care, to maybe even build some innovations on those. And they have a couple of projects very concretely. They have the CareSight platform, which is a tool that combines the digital and human services for patients. And it helps with the coordination with the hospital, does some teleconsultations, remote monitoring, the things we just mentioned. There's also a partnership with Medtronic, which is around or about making sure that we improve the patient care, but by implementing and using AI and the health data that is available. So all of the wonderful stuff. And obviously they have a specific track on AI for health, to really have a clear view. And I think as a general practitioner, that might be very interesting for you as well, Keith, is, having a clear view on the patient histories to make sure that you know where the data is and what is the essential part of the data. Their goal is pretty amazing. So they really want to serve 500 million euros in revenue by 2030. So that's we know that the Poste, with all the packaging services and the online buying and all the digital emailing and all sorts of things, they kind of completely lost their business model. And it's very remarkable how that company shifted into health support, health services, to actually try to achieve 500 million euros in doing that. And they really want to become, by doing so, a leader in digital health and home care in Europe.
So, Christophe, if I may, what I like about La Poste, it's not just all that technological part that you just mentioned, but there's also a human part, because they are sending the postmen and postwomen to visit the people at home and to check on them. That's an additional service that they're offering. It's one of my favorite, no? Because the human aspect is still here.
Yeah, totally good.
So I'd like to piggyback on that just for one. What I also love about the Poste, it's not a healthcare company. And what I see in remote solutions is that everything that a healthcare company does not want to do is kind of shifted into the responsibility basket of the patient. So we see kind of a dumping sometimes of responsibilities towards the patient. And what I love about the Poste is that in terms of education, let me give you an example. Aline, you just mentioned, with AI, we can help people understand their results. Maybe it's not their responsibility to understand the results. Maybe they should just be able to understand how the form is structured and what value says what. And that might just be enough. I think the push to know exactly, your cholesterol is high, your cholesterol is low, that means that you can do this with education. I think the volume of information and the responsibilities that we might be dumping just because we don't want to do it anymore as a healthcare company might be a tricky one. So I'll give you an example. When I was at Wunderman, the call center of a famous telecommunication company just got red hot at certain times of the month when people got their bills, right? And what they said is, we cannot staff the call center enough to answer every question people have about their bills. So basically, they created a video where they structured the bill and they said, this section is about that, this section is about that, this section is about that. And you saw the call just going down. So not, you spent that much or anything, just understanding the structure. And that's what I'm really, trying to convey here is we should be really, really careful when healthcare companies try to so-called empower patients. I think there's some things that needs to stay with you, right? And then just dumping responsibility towards the patient because it's convenient for us and we have a high workload and high churn and people are absent and things like that is something we should be really, really careful about.
Yeah, patients definitely want to have more responsibility, or so a large part of the population wants to have more responsibility until the point they get more responsibility, of course, and then it becomes a little bit more tricky. Keith, you wanted to jump in when I saw it, you reacting when Aline was saying there's a human being visiting the homes of people.
Yeah. So when we talk about continuity of care consists of three components: information continuity, management continuity, and relationship continuity. And speaking to Mo's point, first of all, if the patient or person and their family is to be part of this, then what they really need to be able to do is they need to be involved throughout and not just have responsibility dropped on them in between times as well. So I think we have to work well there. Sorry, my dog is whimpering and wants to get left out. Hold on. I was in mid-flow. Apologies for that. So that's part one. The second thing as well is that, speaking to Aline's point as well, I always talk about this. Healthcare has two components, health and care. And we're indexing very, very heavily on the health aspects here as well. And the health aspects has more proportion, which can be delivered transactionally or remotely. My observation is care, feeling cared for, is something that even now is almost uniquely human as well. And so this is why I think what you were saying with La Poste that is important is that for a person to feel cared for, a human either needs to be there, either vocally or physically, and so on. This is why it was always interesting when I saw companies like Uber delivering healthcare services as well, trying to match where the humans are and increasing the care that they provide. And then where possible, those components of health, either collecting information, making sure that the management is consistent, and then if possible, having that person, persistent between so a person can develop a relationship. I think those are the sort of things that work well when you have something such as Aline described.
Dorothee?
Yeah. For me, care is it's about to care about something as well, not only about a person. So I think why it gets more and more adopted is because we don't have time to care about someone. And this means, for example, at the end of life or palliative care, it takes lots of time. The people have no place in their hospital, and then they are sent home, and their relatives want to take care of them. But the people take care of us as caregivers as well. So help us to manage this situation. I think care at home is important as well, to provide information, to provide just support. So it's not only the human factor, it's sharing information. And there's a really nice platform called Guarantee. I think it's called Guarantee. They're from Chicago. And it came from a personal story from a lady, her father died. And she said, nobody's really giving support to caregivers and people at the end of their lives. And you are stuck with papers, who to call, payers, providers. And so she opened a platform which is funded with 10 million to help exactly with these processes, which have not really to do with taking care of the patient, but caring about the whole process. So I think it's important as well to add this to the whole story.
Yeah, totally. And if you want to hear more about some dead and dying innovations, you can go to episode 40. If you want to hear more about Keith saying or reflecting upon the care part of healthcare, you can go to episode 33. Now, we have been talking about health at home, but we've been talking a lot about health. I think there are some reflections to be made about our home as well, isn't it, Mo?
Well, yeah, here I am again, the old fart, just addressing when everyone is talking about technology, just going back to the basics. I love it. It's my style. So let's redefine what home has become. I thought Dorothee also kind of addressed that, and Keith also addressed that. And I'd love to tackle something that is literally under our noses. It's about the air quality. the air quality, we spend more and more time indoors. Apparently, we spend 90% of time indoors, according to the European Commission. And if you take the post-COVID thing about remote meetings, the technology dependency, remote work, streaming, digital entertainment, home deliveries, we're just very comfortable at home. And there's also an urban challenge is we have more and more people going to big cities. So you get the mix of poor indoor air qualities with degressing quality outdoors. When I'm in London and I see someone running during rush hour, I ask myself, what is the net gain, of doing a workout at 5 o'clock in the afternoon? And we also see it, children aren't immune either. 60% of European kids spend less than 2 hours a week in nature. We're living more and more inside. It's winter. And what do we see, Keith? Influenza, RSV, rhinoviruses. So there is a trend where I think a low-tech thing would be investing in improving our air quality. Did you know that, for instance, if you stay inside and you don't ventilate properly, that the quality of the air inside could be 5 times worse than the quality of the air outside? And then what do you get? Well, you get the trend of urbanization. 75% of Europeans now live in urban areas, and it will be 84% in 2050s. This means the same space for more people. People will live smaller, in smaller areas. And then the last trend is that the majority of people will not own their homes anymore, which means that structural investments to do ventilation, to build your house in a way that is healthy, will also decrease. So I think indoor air quality is kind of a blind spot. It has a lot of consequences. 6.7 million deaths globally are linked to air pollution indoors. So I'm not talking about the consequences: asthma, cardiovascular disease, cognitive health, cancer, and things like that. So I think the blind spot for me when health at home is the redefinition of how we spend time at home, how long we spend time at home, our relationship with indoors, outdoors, the worsening conditions, and then some people, and then I think the lack of equity in the poorer and the lower social income classes, having less access to things that could really affect indoor air quality. So it's right under our noses, literally, so take a breath, take it in and think about it.
It's a good one, and it is largely a blind spot. I think since COVID, we're less blind about it. I would put it that way. But one of my clients is actually a ventilation company. You know it more, and since 15 years already, they've actually decided to not compete with the competition at the level of price or at the level of performance, but they position themselves as a company that creates healthy spaces. So everything they do, all their products are called health boxes. So it's really, they make your space healthier. And there's a lot of startups that is now coming up. There's one in Belgium that I know really well, but there's a lot of them out there in Europe and the States that actually try to mimic the benefits of a forest into your home. So what they're trying to do is they inject the homes with microorganisms that they created themselves. So I have one here which is called, and I find it so funny, it's the Air Probiome S1. That's the designed microbiome that they inject into your air to actually decontaminate the air by removing the toxic ammonia and then the VOCs that are in there. But they also will try to help some more human probiotic generating in your homes and lowering all sorts of salt and what have you all in the air out there. So things are changing, but it definitely is a thing that is still a large part of our blind spots. I think that is about it for Healthusiasm. There's still, unless you have still one Healthusiasm on health at home. Otherwise, I'll go to some unusual ones to wrap this podcast, if you will. Keith, I'll start with you. It's the biggest one. That's why I start with you. It's quite a challenge. So the other ones can definitely chime in or jump in if necessary. But here's the thing. People started building for the first time houses about 10,000 years ago. I think the first establishment of a city, it was in Turkey in Cataluyuk. I think I pronounced it correctly. But that was the first time. The first time that people were no longer nomads, but really living, building houses and staying there. Now, the consequences of that was that suddenly we were living together with the animals. And the waste, even the human waste, was accumulated very close to where people were sleeping and living, of course, because the houses were not created that way. And so it generated a lot of diseases. And because of that, they started building their houses differently. They started thinking about, waste management and sewers and all sorts of things. And so ever since, every time a big disease occurred, and certain periods of times, our homes were changed. So my question to you is, could you name a couple of diseases that actually changed the way that we organized our homes?
All right. Okay. Let's try and think of them as well. I mean, I think the spread of, effluent-based diseases or sort of from going to the bathroom and stuff led to a development of the water closet and so on, as opposed to people just sort of storing things immediately outside their house. I'm always reminded, I'm from Scotland and lived in Edinburgh for a while. And in the UK, people call the toilet a loo. And the question is, why did they call it that? It was because in Edinburgh back in the sort of 1700s, people would just throw their waste out of the window and they would shout, "Regardez-le," as in watch out for what's coming down. Also, "Gardez-le" is what they would shout it in Scots. So that's where that comes from. So I think that was the first one, is about, human waste related diseases. I think following COVID, there's probably some changes coming along as well, especially we're talking about air quality and the like as well will be part of it. Also adequately ventilated homes as well become important. The rise of radon, or particularly radon in emissions as well. It's important to pick that up in certain parts of the world, particularly where I'm from in Scotland and in the southwest of England as well. We've got some of those. Just trying to think what else there might be in there. Actually, I think having toilets full stop is probably the big bit.
Yeah, that was the Romans that did it probably first in a decent way. Dorothee, I saw you very excited when I was asking that question to Keith. Tell me, why are you so excited?
Well, before I did all this innovation stuff, I'm actually a historian by training, and I looked into people's interaction and colonialism. So when the ships went to new colonies, they brought in lots of diseases that were not seen beforehand. And for example, when they tried to colonize the American continent, the British entered Virginia, but they were really not firm of this humid condition, and they really built their houses very close to the rivers. So there were lots of mosquitoes and this kind of stuff. So the first two ships of colonialists died because of malaria, mosquito bites, and these kind of fevers there. So then they decided they have to move the houses away from the rivers. So when new boats came, they said okay, we cannot live in this Chesapeake area. We have to move more inwards because the people die here. So I thought about these kind of diseases first. And then, of course, the big plague that was all over the world on ships and these kind of things. And it's when the plague was there, they were okay, we should not have so many rats in our houses. We should be a little bit cleaner, and we should take a little bit more care of hygiene and this kind of stuff. And it reminded when there was COVID here in Germany, especially in a place like Berlin, where the people are sometimes a little bit more experimental. I saw some people with this old plague mask walking around, and in the evening standing just beside me on the traffic light. And I was wait on. So you feel like this is like the plague, so you have to bring in the old prevention. Yeah. So that's why I got excited, because it came back my old historic.
Yeah. Lovely. And indeed, I think obviously there are different answers to this. In my keynote, I always use the 4 diseases, and one of them is the plague for sure, where indeed we started thinking about ventilation a lot more, because a lot of these diseases we thought already back then are spread through the air. But another change that it made to the house was that actually the living spaces and the working spaces were split up. They were separated. It was the first time, and that was basically because of the plague. Then I think in the 1800s something, there was a bunch of diseases that came about: smallpox, cholera, typhus, yellow fever, those kind of things. And that was in the middle of the antiseptic revolution. So there was the germ theory that came about by Louis Pasteur and Robert Koch, I think, as well, where they started understanding the disease transmission. And it started a new focus on sanitation. And as a result of that, the bathrooms, because we already had bathrooms back then, they used less wood, for example. Or the bathtubs and the sinks started using porcelain in the 1800s, 50 something. Ceramic tiles came about back then, simply to avoid, to be able to clean it better. And then we have, it was put out in the chat by Keith as well here. We have tuberculosis, which came about at the same time as what was called the sanatorium movement. So the understanding that we need to have a lot of fresh air, but also sunlight to kill the germs. And we saw that in the way that houses were built. So more open spaces, more large windows, more white, clean interiors that could reflect the sunlight. We had balconies and terraces that came about, and that was basically the beginning and the sole ingredient of the modernist architecture in the 1910, 1920. And then finally, it has been said by Keith as well, COVID, of course, where we had a bit more focus on air quality, where we wanted to include nature a little bit more focused on outdoor living, and also the fact that we needed to have multifunctional spaces, hybrid spaces sometimes even, to make sure that if we spend more time at home, which is today the case, that we have these spaces where we can feel well. So diseases always have had an impact on the way that we organize our homes, the way that we design our homes. That was the unusual one that I wanted to bring to you, Keith. Aline, if we are at home, we can practice healthcare for ourselves. And there's two types of care that we often, it's actually a new word to me, but I think you can understand what is meant by it. And that is basically my question to you. What is soft care and what is hard care that we practice at home?
Maybe soft care would be relaxation techniques, and hard care would be linked to medicine and drugs.
Yeah, and monitoring and all the solutions that we bring into our homes to actually do so. So indeed, the soft care is really the gentle introspective practice that promotes relaxation, mental well-being, as you say. Yoga by candlelight, morning journaling, mindfulness meditation. Those are the soft care stuff.
Glimmers.
Say it again.
Glimmers,
as we mentioned in our previous cast. And all of the soft care is to reduce stress, enhance self-awareness, the mental health, those kind of things. Hard care is and data-driven practices focused on fitness and biohacking and those kind of things, right? Everything
Christophe,
that we thought about, yeah.
Don't care is also healthy.
And Mo, hard care really gives me a hard time because I don't want to be surveilled all the time.
Yeah.
I'm more
But some attitudes like don't care is also a healthy one. Yeah.
Definitely. Let's stay with you, Mo. You might have some thoughts on this. So we have FOMO, the fear of missing out. We have YOMO, the joy of missing out. And now we have something which is called YOZO or YOST, just JOSO, or sometimes also JOST. What might this be?
So the joy of, I don't know, maybe I have no clue. Maybe it's the joy that you leave WhatsApp groups, Joso, and the joy of just saying, I select where I want to engage, and I'm more select. The joy of selecting out, maybe that's Joso. I don't know.
It's solo, the joy of solo time, basically.
Yeah,
because indeed we have a lot of distractions. We have a lot of places we need to go to, a lot of engagement, a lot of notifications, all of that thing. And so the idea is to take out some time to spend alone.
I know. Yeah, because people who follow the podcast know that every year I go into a 3-week workation where I'm just on an island, and to my left is the sea, to the right is the sea, and I'm able to be incredibly productive and still spend time with. I find myself great company, as I say. So that's something I can recommend to everyone.
Yeah, I do too. Not 3 weeks, unfortunately, but 3 days. And it's
It's a
not always
start.
next to the sea. It's not always next to the sea.
It's a start.
But I do totally agree with it. Last one, Dorothee. In winter time, we spend probably more time at home, right? Definitely. I mean, Keith is living in the north. You are living in the north of Europe. I live in the north of Europe. Most of the time is living in the north of Europe if you're not spending his time on an isle somewhere. Aline is not spending time in the north of Europe. But if we are spending time in the north of Europe, a lot of people spend more time at home. And during that period, we could develop SAD. SAD. It's a disorder, but what type of disorder is it? Any idea? You've definitely heard of it.
Definitely. So maybe what we are suffering in Berlin from, because it's grey, all shades of grey, I always say 50 shades of grey, from November to March, we miss light. And so any enthusiasm, Belgium as well, any enthusiasm to go out, to really be interactive, to do stuff, this is something we really miss. So, and we are maybe sadder during that season, which we know from Scandinavia. Finland has the highest suicide rates in whole Europe because of the lack of light. So maybe it comes from this kind of...
it's pretty close. But I think Keith knows what SAD stands for.
The seasonal affective disorder.
Seasonal affective disorder.
Cyclical changes. Seasonal affective disorder. Yeah, it's the cyclical changes in the person's mood that's related to the change of season and also daylight. Although, interestingly, seasonal affective disorder also affects people in countries where there is less swing in daylight, and so it's related to this sort of natural variation. And I mean, I've been managing patients with SAD for quite a long time. There was a real vogue back in the noughties for giving people daylight lamps and the like as well, particularly in areas where there's less around. So you'd sit with certain wavelengths and you can still buy them as well. So there's lots of different ways in. They're sort of modestly effective. I think what I've seen on this as well is actually, it comes back to what Mo was talking about earlier on. It's not so much the light, although light is important. It's the nature. It's indoors versus indoors and outdoors. In summer months, people are more outside, and in winter months, people are more inside. And whilst light plays a part, it's actually a bit more general, and that is my understanding, because there is a certain joy in dreich weather and stomping around in the rain and that kind of thing. But it's a common problem for many.
Maybe what helps there, like I spend the time in Norway and where it's pretty dark, but they have a different approach. So they say it doesn't matter how cold it is, you just need to have an activity that is really bringing you joy. So even if it was dark and cold, you go on your sledge, and sledging there is for free. And you have the tram, for example, in Oslo, and everybody's doing it. It has a community feeling as well, because you're lacking community. The same as cross-country skiing there. It's not hard to learn. It's for free. And it gives you kind of a movement. You do stuff, you're outdoors, and even it's dark or something, you get inside, you have a better feeling. So I think there it's really nice to go to countries where they suffer a lot from the darkness, but they found a way to embrace it and do stuff.
Yeah. I think that's one very big part. But I think, taking back Keith's point, our artificial light does not have that infrared anymore. And seeing the sun come up and seeing the sun go down, there's that hue that kind of also, for sleep and everything else, kind of resets your system, depending on melatonin and everything else. So I think we also see, and we see it in the pain clinic, the advantages of near infrared, being on pain perception, mood disorders, and things like that. Christophe, that's one for you. I think an episode on light might also be the connection between light and health might also be really, really interesting. Yeah.
If I can add something quickly here. So I remember a few years ago, I was talking to a psychologist about, people being depressed with like the light going down, etc. And for me, that period of the year was like autumn, no? Like where we are at now. And she told me there's actually more patients suffering from like being depressed in spring, which I was very surprised. But yeah, maybe Keith, like you can know more about that.
I don't know. I mean, there's so many variables here as well. I suppose the important thing is that we all realize and remember that there's a lot at play here. And one, simply changing the light or anything like that is probably not going to be the sole solution for this. There's a bunch of factors. But yeah, it really does vary from person to person. I always like to think about what you were saying, Mo, about that sort of sunrise, sunset. There's an element of nature acting as like the beat of a conductor, and this sort of pacemaker from the natural world that your body then picks up and then casts adrift from that. And you can see this from studies of people going to space, for example, or the Antarctic. That absence of that beat and that rhythm, people's sleep cycle goes out and so on. So yeah, that sort of the rising and setting of the sun, those moments act as an anchor around which your body's natural cycles work. And then as they sort of drift out of sync, you can start to get more problems, is my perception of it. And there's maybe some science and just a little bit more of I've just seen a few more summers and winters and seen people going through them too.
Yeah. And I have to agree with you, Aline. Every time in spring, when the sun gets back a little bit and there's less gray clouds here in Belgium, I'm often get a little bit depressed. I'm not entirely depressed, let's put it that way, but I always often realize then that I decide to live in a great country like Belgium and that it is my own decision. I'm always like, damn, why am I doing this every year? And so I get that same feeling a little bit.
I have to say, I love spring. I can't help the days drawing out longer. Maybe it's
sure, me too. Yeah, but it's like the realization at that point where you say like, oh, I love it. I love the sunshine. I love the blue skies.
Days get and
life
I'm coming back from the ground. Those kind of things, and in particular, it's that sort of going towards the days get longer and the light comes in. And the warmth, and then near us, it's seeing the lambs in the field and daffodils coming out, all these things. I can't help but be very delighted by that.
Lovely picture. By the way, talking about everything that was related to the seasonal affective disorder, you mentioned pretty much all the things that we need to do to battle it, whether it's light therapy, mimicking sunlight, staying active, doing creative activities at home, or increasing social interaction as well. So I think all of these are wonderful. And all of these are things that we can do at home. If we talk about health at home, it's really not just about, bringing in these telemonitoring devices. It's really our home is the epicenter of our health management for sure. And we talked about a lot of healthusiasms there. So thank you. Time to wrap up the Healthusiasm podcast for this week and go home. Thank you for listening. If you like the show, hit the subscribe button on your favorite podcast platform. You can also visit healthusiasm.com to subscribe to the newsletter and learn more about our panelists. For now, I'd like to thank our panelists for their healthusiasm. Thank you, Aline Noizet, Dr. Keith Grimes, Mo Zouina, and Dorothee Marie-Louise Doepfer. My name is Christophe Jauquet. We are the Healthusiasm panel, and we'd love to see you again next week for some more Healthusiasm. Ciao.